Good evening, this is Dr. Nader Hamada and we will talk today about chronic venous insufficiency. We used to teach the venous sessions as varicose veins and deep venous thrombosis sessions, but now actually we prefer to call it chronic venous insufficiency. And this is very important term to understand that even varicose vein, it's a chronic issue. It's not like acute appendicitis or chronic calcareous cholecystitis. If you remove one organ has a problem, then the problem is solved. Actually, most of patients who have varicose veins have a genetic disorder in the wall of the veins, and even if you treat a diseased segment, this doesn't guarantee that other segments will not get diseased in the future. And this is regardless of the experience of the surgeon and regardless of the type of intervention done. Before we start talking about varicose vein and venous diseases and how to take history in these cases, we have to understand this very important drawing. So this diagram actually is the capillary pressure. So this is the arterial side of the capillary, and this is the venous side of the capillary, and this is the intravascular blood, and this is the interstitial fluid and the cells outside. And if you remember your lessons in physiology, there were driving forces, two major driving forces, to move fluids from inside the artery, the arterial end of the capillary, towards the interstitial fluid, and to move the fluids from the interstitial fluid back to the circulation. And these pressures, or these forces mainly, are hydrostatic pressure and oncotic pressure. The hydrostatic pressure, this is a pure physics. The hydrostatic pressure is the pressure that's exerted by the fluid inside any container that tends to get this fluid out of the container. So on the arterial end of the capillary, there is roughly about 35 millimeter mercury pressure, and this pressure actually tends to get the fluid from inside the arterial end of the capillary towards the interstitial fluid. While at the venous end, this hydrostatic pressure drops from 35 to 15, but still this force wants to get the fluid out of the venous side. On the other hand, there is a hydrostatic pressure in the interstitial fluid, tends to get the fluid inside the capillary, and this is 3 millimeter mercury only. And there is oncotic pressure of albumin and proteins. So the albumin inside the vessel start by its oncotic pressure to try to get and drag more fluid toward the circulation, and this actually is a pressure of 25 millimeter mercury roughly, while the protein in the interstitial fluid try to get fluids towards the interstitial fluid by a force of 3 millimeter mercury. So classically, we were teaching the students that actually when you have actually this driving force 35 towards the fluid will filter towards the interstitial fluid, while the albumin tries to get fluid inside the capillary by force of 25. So the net result that actually the fluid will come out here by pressure of 10 millimeter mercury. While on the other side, the albumin is dragging more fluid towards the venous side, more than the hydrostatic pressure of the venous side. So the fluid will come back inside the vein by 10 millimeter mercury force. And this is how the exchange of fluids and nutrients and gases will occur. The fluid filtered on the arterial side will have the oxygen, and nutrients will go through the cells to deliver the oxygen and nutrients, and the carbon dioxide and metabolites will be coming back to the circulation from the venous end. If you understand this diagram, it will be very easy for you to understand all the causes of edema. So for example, albumin is the main force that drags the fluid back to the circulation. So if the albumin dropped because of chronic liver disease, if there is a problem in synthesis of albumin, if the patient has nephrotic syndrome or any other cause that can cause hypoalbuminemia or hypoproteinemia, this would explain to you why the patient will get edema. If the patient has heart failure, this means actually that the heart cannot pump the blood inside it, so the veins will get congested with blood, and this will be reflected on the venous pressure on the venous end of the capillary. So this pressure will be higher than 15, and if this pressure will get higher, the net result of the blood intake back at the venous end will drop, so there will be more accumulation of fluid in the interstitial fluid. The same actually occurs in chronic hypertension. In chronic hypertension, both arterial and venous pressures might get elevated, but especially the arterial side. And with chronic hypertension, you will find this in many patients with chronic hypertension with no obvious reason. They don't have any trouble with their kidneys, with their liver, or with their heart, because their echo is fine, but because of the chronic hypertension, they will have some edema because this pressure is chronically higher than normal. In patients with varicose veins, and more obvious in patients with DVT, deep venous thrombosis, the drainage of the venous side is actually impaired. For the blood to flow from the venular side of the capillary towards the heart, this pressure should be always higher than the proximal vein. So this will flow, if we imagine that this capillary in the foot, and the blood will flow from the foot to the leg, from the leg to the thigh, from the thigh to the pelvis, from the pelvis to the abdomen, and then to the chest. You have to understand, for the blood to flow in this direction, it always has to be higher. The venous pressure in the toes will be higher than the leg will be higher than the thigh, then the thigh will be higher than the pelvis and the abdomen and the chest. This is how the blood will flow. And if the patient starts to strain during coughing, sneezing, during defecation, during micturition, during pregnancy, all this will increase the pressure in the abdomen or pelvis, and this will be reflected on the venular side of the capillary. But because there are valves in the veins and these valves are competent, so the pressure will not get higher, and this will maintain the venous flow from distal to proximal. When the veins get impairment in the valve system, then the pressure here will get higher, and this would explain why the patient with varicose vein will get edema. Another thing would happen in DVT: if the patient had deep venous thrombosis, the blood will not be drained optimally from the venous circulation, and then it will be reflected on this pressure as well, and this is why most of patients who have DVT will get lower limb edema or upper limb edema if it happens in the upper limb. This is just to explain how edema occurs, especially in chronic venous insufficiency, and in the following videos we'll talk more about varicose vein and chronic venous insufficiency.